Good evening to all of you. Call this meeting to order and welcome you all to the Washington Township Healthcare District January meeting. If you'd rise and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Catherine, if you'd take the roll, please.
Yes. Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Dennison.
Present.
Director Eben.
Present.
Thank you. I think it's well to note that Nancy Farber is not with us this evening. In her place is Kimberly Hartz.
Thank you.
Appreciate you being with us, Kimberly.
Thanks.
We're going to take an item from our action items slightly out of order and move directly to item B on the list of motions to be made. Mr. Wallace?
Yes, Mr. President. I move for the presentation of the commendation of Christine Lavoie, and that the President of the Board of Directors, Dr. Stewart, be requested to read the commendation in its entirety. Further, that this commendation be spread upon the minutes of this board meeting as a memorial of the dedicated service of Christine Lavoie to the Washington Township Healthcare District.
It's my pleasure to second this motion.
So we have a motion and a second. Is there any discussion on that? All in favor? Aye. Good. So it's my pleasure to be able to read this commendation for Chris Lavoie, who's leaving the hospital after many, many years of service and has done an outstanding job. This commendation states, in recognition of her years of dedication, caring, and commitment to the residents of the Washington Township Healthcare District, Washington Hospital Healthcare System and the Washington Township Healthcare District acknowledge and praise the accomplishments of Christine Lavoie. During her 38 years of service to the community, Chris demonstrated the highest of ethical standards, exemplifying the patient-first ethic in her roles as nursing night supervisor, clinical coordinator, nursing services supervisor, director of quality assurance, director of professional resources, chief of professional resources, chief of compliance, and associate administrator. Chris provided leadership roles in the Quality Steering Council, the 100,000 Lives Campaign, the Joint Commission Survey Readiness Task Force, the Corporate Compliance Committee, the Institutional Review Board, the Bioethics Committee, the Green Team Initiative, and on Safety and Security Preparedness Initiatives. Chris provided leadership for the Medical Explorer Program. Chris authored the Pearls of Wisdom Handbook for staff, physicians, and volunteers. By virtue of Chris's assignments in nursing supervision, quality assurance, utilization management, risk management, and compliance, Chris has, in the course of her tenure, impacted almost every department. Chris is known for being a compassionate, creative, and physically responsible leader. With highest regards and accolades, we proudly present this certificate in honor of Christine Lavoie, a certificate of commendation, duly bestowed this day, the 8th of July, 2014, by the
January.
8th of January.
I'm sorry. What? The 8th of January. I was all worried about getting the 2014 wrong. The Washington Hospital Healthcare System and the Healthcare District do that. Chris, I'd like to present you with this commendation. Now we'll return to our regular agenda and introduce the educational sessions for tonight. Kimberly, if you could introduce the participants in that for us.
Sure, I'll start with the first one. The first, I'm pleasure to introduce Ruth Traylor. Ruth serves as the Director of Community Outreach for Washington Hospital. In her role, she is responsible for the Community Health Resource Library, the Health Insurance Information Service, Washington on Wheels Mobile Health Clinic, as well as patient satisfaction. Ruth also oversees a number of community programs to ensure that district residents have access to high-quality healthcare services, programs, and education seminars. Ruth attended Xavier University in New Orleans, Louisiana, with a Bachelor of Science degree in biology. She completed her Master's in Healthcare Administration from Tulane University School of Public Health and Tropical Medicine. She is active with the American College of Healthcare Executives and volunteers with SAVE and Abode Services. She will be presenting tonight Washington's Hospital's Community Health Needs Assessment.
All right, thank you, Kimberly. Good evening. As Kimberly mentioned, I will be presenting the 2013 Community Health Needs Assessment. Although we are in 2014, this was conducted in the year 2013. And community health needs assessments are conducted every 3 years. And this needs assessment was conducted in collaboration with the Hospital Council of Northern California, Alta Bates Summit Medical Center, Children's Hospital Oakland, Eden Medical Center, St. Rose Hospital, the Alameda County Public Health Department, and the City of Berkeley Public Health Department. In 1995, a law went into effect here in California requiring not-for-profit hospitals to conduct community health needs assessments. Since Washington Hospital is a district hospital, we're actually exempt from that law. However, we chose to go ahead and conduct community health needs assessments because we realize the value that the information provides in helping us to address community concerns in our district. With the passage of the Patient Protection and Affordable Care Act, it became a national mandate that all not-for-profit hospitals conduct community health needs assessments and adopt implementation strategies. I would like to say that Washington Hospital has continued to conduct the community health needs assessments, and even before these were put into law, Washington Hospital has always been very focused on our community and has always worked with the community to determine what the needs are so that we can develop appropriate programs and services. The enactment of these laws just helps to formalize the process. For the purpose of this report, we will be covering our district area. One of the requirements is that although we worked with several different hospitals in Alameda County and the assessment provided an overview of all of Alameda County, we have to focus and provide a report specific to our district area. So for the purposes of this report, we will be covering Fremont, Newark, Union City, Hayward, and Sunol. Now, I'd like to make a note for Hayward. Our district area covers 2 zip codes in Hayward, 94544 and 94545. However, the area in 94545 is actually a golf course, so there aren't any people living on that golf course. And so we focused only on the zip code of 94544. And even looking at our district area, we don't encompass the entire zip code, only at certain streets, but we couldn't break the report down that small. So as we're going through the report, when you see Hayward, that is referring to the one zip code of 94544. For our methodology, we use both quantitative data and qualitative data. Here's a partial list of our quantitative data. I do want to talk a little bit about our qualitative data. As part of the Patient Protection and Affordable Care Act, it requires us to go out to our community to gather input. And so we worked with 12 key informants in our district area, and these are leaders in the health and social service areas that have a broad aspect of the needs of our community. And we also conducted focus groups with our constituents. I will be covering the following 7 areas throughout this presentation, and I do just want to bring your attention to the asset mapping, which is the last area noted on this slide. Asset mapping will appear throughout the presentation, and it points out the available services in our community. So I primarily will be focusing on the services that Washington Hospital already has, but I will also go into additional services that are available in our district area that may or may not be provided by Washington Hospital. Looking at demographics, With our recent statistics, our estimated population for 2013 is approximately 338,000. At our last census, our population was almost 328,000. So we dropped from the estimates in 2008. However, in 2013, we do see that our population is continuing to grow. When we look at our race and ethnicity, we'll be starting with the lavender area, and that is our Asian population. And in Fremont, it's approximately 45%. In Newark, it's 26%. And in Union City, it's 53% of the population. Moving on to the teal, which represents our white population, we have 30% in Fremont, 29% in Newark, and 14% in Union City. Looking at our royal blue, which is our Latino population, we have 17% in Fremont, 35% in Newark, and 22% in Union City. The yellow represents our African American population, and it's 4% in both Fremont and Newark, and it's 6% in Union City. And the kind of gray up top represents our Native American and Pacific Islander, and you'll see 1% in Fremont and in Union City, and 3% of the population in Newark. And lastly is the magenta color, which you'll see, and that stands for multi-race. And for all cities, it's reporting approximately 4%. Now, this next slide looks at aging in place. So it represents the age categories for our district population. And one thing that you'll notice in the lavender section, those are our 20 to 44-year-old category, and the yellow are 19 and younger. You'll notice that these two populations are actually decreasing. And our 45 to 64, which is the blue, and the 65 and up, those populations are increasing. And what that shows us is that our population is remaining in the district as they're aging. And excuse me, as I'm giving this presentation, I'm battling a cold. And I would like to say that we don't have as specific information for the other cities. However, in Fremont, I can tell you that 21% of the Fremont populations have one or more people that are 65 years of age or older. 5% of Fremont households have an elderly person age 65 or older living alone. And 7% of individuals that are 65 and older in Fremont are living on less than 200% of the poverty level. This slide will come into play a little later in our presentation. Looking at our uninsured, you'll see the gray here is our national rates of 16%. The yellow is our state rates at approximately 22%. And the magenta are Alameda County rates of uninsured at approximately 15%. And in looking at the Tri-City area, Fremont, Newark, and Union City, we're all approximately 10% uninsured. It will be interesting to see in a year or two after the Affordable Care Act has taken off on what those rates will look like. Moving into life expectancy, one thing I can say about this slide in comparing from 2008 to 2010 is that people are living longer. With the exception of Hayward here, this is only the one zip code, 79.5, whereas in 2008 we didn't have it broken down to the zip code level, so it was 80.5. So that may look like it's dropping, although if you take the whole city of Hayward into account, it may not be decreasing. But you will see that for the rest of our district area, we are above the state and national rates for our life expectancy. And looking at this slide, it's very busy, but the one thing I do want to say is that our death rates are decreasing. The yellow is 2002 to 2004 timeframes, and the blue is our recent timeframe, 2010. And as you can see, our death rates are decreasing in all areas. Infant mortality. The Healthy People 2020 goals, which are national goals for health, has infant mortality set at 6 per 10,000. In the state of California, it's 5.2, in Alameda County, 4.3, and this is for 2010 data. You will see that Newark and Hayward are above the county rates, although we're below the state rates. And Union City and Fremont are below both the county and the state rates for infant mortality. Looking at overweight and obesity, Broken down by state, we'll see that by city, Fremont has approximately 27% that are overweight and 13.2% that are obese. And when you look at all of the cities that we had data for, they're all right in the 25 to 28% for being overweight, and the obese is somewhere between 12 and 16%. So there is a lot of work that needs to be done in terms of healthy weights for our population. Now, as I mentioned before, we'll be talking about asset mapping. And so for Washington Hospital, we have a number of programs currently addressing the last slide, which is our overweight and obesity. We have an excellent nutritional services department here at Washington Hospital. They provide over 4 dozen community education sessions, lectures, health fairs, et cetera, throughout the year. They also participate in national nutrition and health initiatives. And they also have a garden here on campus where they grow fresh produce that are used for our patient population as well as in our cafeteria. And we've also aired a number of public safety announcements around healthy eating and staying active. Let's jump into chronic diseases. Looking at diabetes, we're first looking at our mortality rates for diabetes. The Healthy People 2020 goal is to be at 6.6 per 10,000 for the mortality rate for diabetes. I can say that our area is much below that rate, so we have definitely met the Healthy People 2020 rate already in 2014. However, we want to make sure that we don't see these rates increasing. One thing I do want to point out on this slide is that when we looked at the data in 2000 to 2002, which in Newark, we were at approximately 3.3 for the mortality rate. You'll see that now, in the most recent data, 2010, we were down to 1.4. That's a significant decrease of more than half in the last 10 years. So that's something to be noted. When we first looked at the data in Newark, we did a lot of outreach in Newark to educate and screen the community. Now, we can't say that that's had a direct correlation on these numbers, but we do hope that they've had somewhat of an impact. Looking at diabetes ED visits, Newark is high in the ED visits. So while we are seeing them decrease and being one of the lowest in terms of mortality rate, they do have a high emergency department visit rate for Newark. And it is higher than the county and the state rates. So that is something that we are continuing to watch. When looking at hospitalizations, once again, Newark is the outlier with a higher rate than the county and the state. And these rates are all per 10,000. We do have a number of programs here at Washington Hospital related to diabetes. We have an American Diabetes certified outpatient diabetes center. We provide group and individual classes. We provide pregnancy support. We also have a wound center that addresses wounds, especially for diabetics that may have non-healing wounds. And we provide a number of screenings and education sessions for diabetics. Moving on to hypertension, our emergency department visits. Hayward is the outlier, and this is the 94544 zip code. However, Newark and Union City are also above county rates, and although Sonoma and Fremont are below county rates and state rates. When we look at hypertension hospitalizations, once again, we're seeing Hayward as the outlier with rates above the county and the state rates. Although the remaining cities are right in line with the county and the state rates. Looking at heart disease, and as I mentioned before, we looked at the slide of aging in place. So I want you to keep that in mind as we're looking at these hypertension and heart disease and stroke slides, because as our patients are remaining in the community and aging, it's not unlikely that they will have heart issues or suffer from a stroke. So some of these numbers are high as we're going to go through these slides, but keep that in mind as we're looking at the data. So here we're looking at our mortality rates for heart disease. And the 2000 to 2002 data is the green at the bottom, and the red is the most recent data with 2010. And what we see here is that Fremont and Newark have jumped a little bit since the last reporting period of 2006 to 2008 for mortality from heart disease. So we're continuing to watch this and look at our programs around heart disease. When we're looking at emergency department visits, our Alameda County and state rates, all of our areas except for Sunol are above the county and state rates. So we are actively looking at our heart programs and what we can do with our community around education of heart disease. Hospitalization by city, we're looking at data from 2006 to 2008 and comparing it to data from 2011. And our rates are either remaining the same or decreasing on hospitalization. So that is good information that we're actually having less hospitalizations over time. So we're continuing to watch that, but we're seeing a decrease in the hospitalizations. And looking at our cardiac services, we are a cardiac receiving center in Alameda County, and we recently expanded and remodeled our cath labs. We also have a cardiac rehab program, and we provide a number of screenings for the community as well, and as well as community seminars. Okay, moving into stroke. Our stroke rates continue to decrease. Once again, the green is the 2000 to 2002 timeframe, and the red is the most recent 2010 timeframe. At the top, we have our state and county data, and you will see here that our district area are all below the state and county rates for stroke mortality. Emergency department visits. With the exception of Newark and Union City are above the county rates, and all of our areas are above the state rates for stroke emergency department visits. Now, I will say that our mortality for stroke is decreasing, and so that means that people are not dying from stroke, but we still have patients coming in to our ED, and you'll see with our next slide, as well as hospitalizations. This can be good or bad. One is that people are not dying as often from stroke, which means that they are understanding the symptoms and hopefully getting themselves to a hospital if they are experiencing symptoms so that we can then provide treatment and hopefully they will have better outcomes. Our main goal here is to educate people on how to prevent stroke so that we can see these numbers come down. Looking at our stroke programs, we are a primary stroke receiving center. We are one of 3 in Alameda County. We're also a Joint Commission certified stroke center. And in 2013, we received the American Heart Association Gold Plus Award. We also provide an annual stroke awareness screening where we screen approximately 120 people a year for stroke. And we have a monthly stroke support group. So we have a lot of programs around stroke, and we continue to do more. Looking at asthma. These are all ED visits in the blue for all ages combined, and then the purple are emergency department visits for children ages 5 to 14. And you will see that our rates, with the exception of Fremont, are above the county and state rates for asthma emergency department visits. Looking at hospitalization, for the state and county, they did not break it out by age group, so there's really only one indicator, which is the 70.5 for the state and 91.7 for the county. When looking at our adults and children, adults have more hospitalizations than our children, and that may be because they're older and they may have other underlying health issues which require hospitalization. Moving into mental health. Looking at our mental health emergency department visits, all of our areas are right in line with the county rates. However, they are above the state rates for emergency department visits for mental health. For hospitalizations, Hayward and Fremont both have rates higher than the county and state rates. Looking at mental health, substance abuse, mental health, ED visits and hospitalizations. Once again, Hayward is the outlier. And with the exception of Newark, the areas in Fremont come in at or below the county and the state rates. And then in looking at hospitalizations, once again, Hayward was an outlier as having one of the highest rates in the area. But the rest of the county does come in below the state and the county rates, or the rest of the district area, I should say. Suicide, the Healthy People 2020 goal is 1 per 10,000 for suicide rate. And in 2010, the state rate was 1.1, the county rate was 0.9. So they're right in line. As you can see, Sunol's rate was 1.3, Hayward 1.1, Union City 1.2, Fremont was right on at 1, and Newark was 0.7. When looking at self-inflicted injuries for ED visits and hospitalizations, once again, Hayward had the highest rate in our district. And Union City, Fremont, Newark, and Sunol all came in at or below the county rates. And hospitalizations, almost the same. Newark was slightly higher than the county rate, but Hayward once again was the outlier. And in terms of mental health services that Washington Hospital provides, we do have crisis counselors stationed in the emergency department, but we do know that mental health services, especially on an outpatient basis, are very limited in the Tri-City area, and especially for the youth. Currently, we're looking at plans for an outpatient clinic, and in the last 2 years, we have aired public service announcements regarding mental health. Cancer. So the Healthy People 2020 rate for cancer mortality is 16.1. Our most recent data for 2010 is the red up top, and then 2002 to 2004 is the bottom, which is kind of the pink fuchsia. As you can see, all of our rates are below the Healthy People 2020 goal, which is good. And Newark and Hayward, though, are either at or slightly above the county rates. And then in terms of the California rate, Hayward is above the California rate, but the rest of the areas are below. Looking at lung cancer emergency department visits, the county rate is 3.5 and the state rate is 2.6. With the exception of Newark, all of our areas are above those rates. So we do have a higher number of emergency department visits related to lung cancer. In terms of hospitalizations, the county rate is 9 and the state rate is 8.3. We are below those rates with the exception of Sunol. Now, of course, Sunol is a small city, so if you have 2 patients, it could really skew the data, but still it's something to keep in mind. Looking at colorectal cancer, our California state rate is 1.7, Alameda County rate is 2.5. With the exception of Fremont, our district area, Fremont and Sunol, our district area are above the county and state rates for colorectal cancer. So this is another area that we are continuing to watch and develop programs around. Hospitalizations for colorectal cancer, Newark came in really high on this one at 9.4, which is well above the county and the state rates. Hayward came in above the county and state rates as well. Looking at female breast cancer, the county rate is 8.5, the state rate is 6th. We are above in Newark and Fremont. And then, Newark and Hayward, and then Fremont is above the county rate. So once again, another area we can continue to watch. Hospitalizations from breast cancer. The county rate's 11.4, the state rate is 5.4. When you look at that state rate, we exceed the state rate in all of our district areas. And in terms of the county rate, we're right on with the Hayward zip code, and then the Sunol zip code is slightly above our county rate. Prostate cancer, emergency department visits. 8.6 is the county rate, 5.4 is the state rate. We're above the state rate in all of our areas, and in Union City and Newark, we're above the county rate as well. So once again, prostate cancer is of a concern in our district area. Hospitalizations from prostate cancer. We are below the county and state rate for hospitalizations for prostate cancer in all of our district areas. Looking at our cancer services for Washington Hospital, we have a number of accreditations throughout our hospital, including our radiation oncology center, our breast ultrasound, our mammography, our stereotactic breast biopsy. We're a breast imaging center of excellence. We also received the Outstanding Achievement Award from the Commission on Cancer. We have an infusion center, a gamma knife program, so we have a number of programs aimed at cancer. And so we're really work on those in terms of educating the community to let them know what services are available and really work on early detection and prevention. Looking at our safety profile, in terms of assaults, Hayward was higher than the county and state rates, although the rest of our district area was in line with the county and state rates. And in terms of hospitalizations, it looks the same as our ED, and with Hayward being higher than our county and state rates. Unintentional injury deaths. What we'll see here is the Healthy People 2020 goal is 3.4, and we have met that Healthy People 2020 goal. And with the exception of the Hayward zip code, we are at or below the county and state rates for unintentional injuries, deaths. When looking at our ED visits and hospitalizations for unintentional injury, Hayward in both areas is higher than our county and state rates. And Sunol came in high for our ED visits for unintentional injury as well. Looking at accidents, car versus bike, we are above the state rate for Hayward, but the rest of the areas are below the state and county rates. And for hospitalizations, all of our areas are below the county and state rates. Now, unfortunately, we didn't have data for pedestrian versus car, which is a big topic here at Washington Hospital. I do want to address some of our concern for safety. One thing is that we are building our brand new emergency department and Morris Hyman Critical Care Pavilion, so those plans are in the works. And once those are built out, we do plan to apply for trauma center status so that folks that are injured in our district no longer have to be sent out of the district for care if it's related to a trauma. And with our crosswalk, we're working with the city currently to develop hopefully a light at the crosswalk. So those talks continue. However, we have spent over $300,000 to improve the safety between our two buildings here on campus, including installing the crosswalk and making modifications. In addition, we air public service announcements on our InHealth channel regarding safety issues, and some of those include texting and driving and car seat safety. And here we just have a list. It's not all of our services, but it encompasses several of the programs here at Washington Hospital that help our community that may not necessarily fall into one of the categories that I spoke about earlier. Okay, let's go into our key informants and focus groups. So once again, the key informants, this is not a complete list. However, these are some of the key informants that provided input in terms of our health status of our community. We also provided focus groups, a total of 3. 2 were in Fremont, 1 was in Union City, and we had a total of 29 participants in those focus groups. Some of the information that came back from our focus groups included what did they see as the biggest health issues or conditions. And I will tell you that mental health came up as the most frequent response in terms of the biggest health issues or concerns. That was followed by chronic diseases, respiratory health, dental health, and obesity. When asked who struggles most with health issues, the most popular answer was the youth, followed by homeless, the under or uninsured, immigrants who speak English as a second language or who are monolingual, the elderly, and the low income. When asked what are the leading causes of health issues, the top response was nutrition, and some of the comments were it's difficult to access healthy foods. Healthy foods are more expensive than canned or fast foods. Some said that they cook food too long or they eat a lot of fried foods, so the nutrients are often cooked out. Culturally, people stated that they have to eat what's in front of them, otherwise it's rude or disrespectful to leave food on your plate. And long hours at work, and by the time they get home, they don't have time or are too tired to cook a healthy meal or go for a walk. Also, in terms of leading causes of health issues, access to specialists. So for uninsured community members to get to Alameda County Medical Center, if they don't have a car, it can take BART and 3 buses to get there. In order to get an appointment for specialty care, especially at Alameda County Medical Center, it can be 6 to 9 months. In terms of transportation, they mentioned that a 7-minute trip in a car can take an hour and a half if they're taking public transportation. And some said they're unable to travel to Oakland due to the cost of transportation and gas. Another one are mental health. They mentioned that there is not treatment for youth in South County and it's limited for adults. Gyms aren't affordable. There are communication barriers with language. The lack of awareness of available resources. So we may have a lot of resources in the community, but people are not aware of what they are and how to access them. Also, fragmented health care, lack of a permanent home, and then tobacco use. In order to improve the health, many said that We need more staffing or greater capacity at community clinics. They talked about more efficient partnerships between hospitals and community clinics, more promotion of how to live healthy lifestyles, and improved access to specialty care, including vision and dental services. And then a better economy also came up. And then what do health systems need to know to improve the health? They said to be more visible. They wanted to see more collaboration between hospitals and clinics. They wanted to expand the capacity for community clinics, and they talked about health fairs. And we have a number of collaborations. One includes the South County Partnership, and that is a collaboration of several clinics and organizations in the Tri-City area, and we all work together to address the needs of the community. And looking at our health asset mapping, I have a list here of a number of programs that address cancer and chronic disease, and you'll see some of the programs are related to Washington Hospital and some are provided by outside organizations. I won't read that list, but you can see the different services. And then here we have a list of the various hospitals and clinics, as well as mental health services in the area, and programs for the youth and for seniors, and then programs for housing and violence prevention, and dental and nutrition. Now, previously I mentioned that they said there is not enough for dental and vision. I will say that if you are not insured and you need dental services for adults, there really aren't very many programs for adults to have preventative care. Tiburcio Vasquez does have a dental clinic. Unfortunately, they will only provide extractions. That's the only thing that is covered. So preventative care is not provided for those that do not have dental insurance. So you're either paying out of pocket or going without. All right, that was a lot of information. Are there any questions?
First of all, it was really fascinating, Ruth. Very, very interesting. Fun to see those numbers, and fun to see what the hospital is doing to react to those numbers. Appreciate what you've done there to present that. Any other questions from the board?
Yeah, Ruth, in your focus groups with the community participants, what did you glean as far as the biggest unmet need with respect to mental health? What is really needed, and what could be our best response to that?
They seem to say that there's a lot of depression, PTSD, general anxiety, and then also that they're seeing a lot of issues with youth and substance abuse. And they just don't know what to do or how to address it. And some of them are not even sure what the mental health issues are because they have not been able to get into the system. So honestly, access and understanding how to seek treatment was a big concern. And then anxiety, depression, PTSD, and substance abuse came up as the biggest areas where help was needed.
So not necessarily inpatient treatment, but more in the way of outpatient treatment and education.
Correct.
With respect to mental health issues.
Correct.
Thank you, Ruth.
Yes, Pat.
It's how you collect the data. In Fremont, there are a number of nursing homes and board and care assisted living facilities. I think there are about 5 or so board and cares in Newark, and I'm not sure if there's any at all in Union City. How is that data from those facilities incorporated into all of this?
So what we look at is anyone that has a residence that is stated for the district. So if it's at a board and care facility in Fremont and they have a visit to the emergency department, that is captured. So it may impact our rates if we have more board and care facilities in the area. In looking at data, though, the data is collected the same across the county. And so really we'd have to look at how many board and cares are in Oakland, in Berkeley, Castro Valley, et cetera, to see if we're on par with the number of board and care facilities in all of the areas to compare apples to apples with the rates.
Okay. Thank you.
Thank you again, Ruth.
All right, thank you.
Appreciate all you do there. Kimberly, if you could introduce our next presenter.
All right, our second presenter is Mintu Denon. Mintu did her undergraduate work at UC San Diego and received her doctorate degree in pharmacy at UC San Francisco in 1989. After graduation, Mintu moved back to San Diego where her family resided and started her career at the Naval Medical Center as a clinical pharmacist specializing in infectious disease. After a couple of years, she continued working closely with the infectious disease department, involved in clinical research with several local and national presentations and publications, and also assumed the role of clinical coordinator for the PharmD student program and other pharmacy clinical services. Mintu moved to the Bay Area and started at Washington in 1995 after getting married. She started as a clinical pharmacy specialist and later assumed her current role as director of pharmacy in 1999. Mintu is a member of many professional organizations, including the American Society of Health System Pharmacists, California Society of Health System Pharmacists, and others. And so tonight she will be giving a presentation on pharmacy residency.
Thank you. Good evening. Thank you for allowing me to share with you one of my 3 goals as I set out about 18 years ago or so. And it seems like it was just yesterday I came and talked to you about clinical pharmacy services here. It wasn't that long ago. I think some of you might remember my presentation back then. I started here about 18 years ago under the direction of Steve Koska. Some of you might remember. Steve recruited me here to start the clinical program. Actually, we had a clinical program back then, but he wanted me to advance the clinical program here. So I cost justified the first clinical specialist position. And that was, I can't believe it's 18 years ago or so. So after Steve left, about 14 years ago, I started, I took on the director's position. And it actually was a perfect position for me because it allows me to pursue some of my passions. And some of my passion is for education, evidence-based practice, quality care, and especially patient safety and quality pharmaceutical care. So today, what I wanted to talk to you a little bit about or share with you about is one of the 3 visions I set out 14 years ago. And it actually came to fruition this past year, which I'm very happy with. So what is a pharmacy practice residency program? So in the pharmacy world, you once go through an undergraduate degree, and it takes anywhere between 2 to 4 years to get your undergraduate degree and fulfill all the requirements required for the PharmD program. So you move on to a PharmD program, which is the doctorate program. It's a 4 years PharmD program, and after that, you can graduate from the program and apply for any pharmacy position. You are a licensed pharmacist at that point. A pharmacy practice residency is another extra year of training. It can be either 1 to 3 years of training, postgraduate training after the doctorate program. And the first year will be just a general pharmacy practice residency, and the year 2 and 3, you go more into the subspecialty residency. It can be in cardiology, infectious disease, critical care, multitudes of things. It's actually a formal, educational, hands-on program that allows a resident to participate in various patient care settings and really to sharpen the knowledge and skills. And I'll go on a little bit later on why we need this. As far as screening criteria is concerned, we had a lot of applicants this past year. And we had to come up with some screening criteria. The residents we applied, the residents applied, or the students, the graduate applied, the GPA we looked at is above 3.2. And actually, for us, since we had so many applicants, we actually cut it off at 3.5. The kind of rotations they did, since we are purely inpatient hospitals, I'm looking at, candidates with inpatient experience as a student's working experience, community service, research projects, and really personality. At the end of the day, you need to have a good personality if you're going to be working in a patient care arena. We did a panel interview conducted for these eligible candidates. Our mission statement for the program is to prepare the resident to provide optimal, compassionate patient care, that's the key, educate self and others, optimize drug therapy outcomes through incorporation of evidence-based medicine and research, and demonstrate commitment to the pharmacy profession. This all goes into my passion of pharmacy here at Washington Hospitals. To ensure that the program deliver high-level standards, the American Society of Health System Pharmacists, who is the accrediting body for the residency program, actually set out goals for us. We have to meet these goals. First off, manage and improve medication use process. We have to show how we do that. Provide evidence-based, patient-centered medication therapy management with interdisciplinary teams. When we go through school, we basically learn about pharmacy. When we go out and practice, we need to interact with other team members too. So this is important part. It's an important part through the training. Exercise leadership and practice management skills, demonstrate project management skills, provide medication and practice-related education and training, utilize medical informatics, conduct pharmacy practice research, and participate in the management of medical emergencies. We have to fulfill all these program goals in order to be accredited. So as far as how many programs are there nationwide, there's about 780 pharmacy programs. The first year residency program nationwide. In the hospital setting, there's about 650 out of those 780. In the community setting, in the AmCare type of arena, there's about 60 residency programs, managed care 35, clinics, home care, Department of Health, there's about 20. The estimation from the American College of Clinical Pharmacy is that by the year 2020, residency training should become a prerequisite for entry into pharmacy practice. And I can tell you, during my tenure here, most of the candidates I hired, or most of the pharmacists I hired for the department, are residency trained from accredited programs. Because my feeling is that working in a hospital setting, it is very complex. When you first graduate from pharmacy school, you're really scratching the surface with a lot of these topics. You really need that extra year of training in order to practice in a complicated environment that we're practicing in today. And the data actually shows it too, because if you look at the number of pharmacists employed in 2001 versus what the prediction is in 2020, the order fulfillment dispensing, these are the pharmacists that you see at the Walgreens, the outpatient setting, the refill centers. In 2001, there was 136,000 pharmacists employed. The estimation is in the year 2020, you expect that number to go up because of the number of medications patients are on or whatnot. But actually, if you look at the data, it will go down. The prediction is it will go down. We will only need about 100,000 pharmacists. And the reason behind that is because of all the automation. We're refilling prescriptions for 90 days, not 30 days or 10 days anymore. A lot of things in the outpatient world is automated. There's refill centers. So you don't need as many pharmacists out there with the machineries that we have. In the patient care arena, on the opposite end, there's 48,000 that were employed in 2001. The estimation is in 2020, we will need 295,000 pharmacists to really look at medication management, the complexity of medications and the interactions between the medications. We will be needing more pharmacists there. Indirect or others, 12,000, and this goes into like the research, the home care, and that type of thing. In 2020, we need about 22,000. So in total, we have about 200,000 pharmacists or so in 2001. The need will double in 2020, but in different arena. We will be seeing more pharmacists practicing in the patient care arena versus in the distribution or dispensing outpatient arena. And because of that, we do need a residency program because of the complexity of the therapy. So what is the value of a residency program? The true value, I think, is really the education component. You bring in the evidence-based practice, you stimulate your staff, the staffing, recruitment, development, satisfaction, because as you know, once you graduate from a program, you start working, your interest in really keeping up with data and evidence-based practice, you don't have time anymore. So by having a residency program, you continue that learning environment. The residents are here, the students are here, because in order to have a residency program, you have to have a strong base, clinical program base, strong preceptors. You have to recruit good staff to train the residents. And with that comes the students program. And the students program brings in education. It constantly keeping you stimulated. And it also increase the capacity to deliver education and scholarships, and education not just within the pharmacy department, to the nursing department, to the medical staff. And the residents work with multiple different disciplines besides just pharmacy. Accreditation versus non-accredited pharmacy residency. What is that? The difference between an accredited residency program is that ensure a certain level of standards. The accreditation is given by the American Society of Health System Pharmacists, which is our national organization. In order to get accredited, to be accredited, you have to graduate your first year of residency, of residence. So the first year, you're in a non-accredited state. After you finish the first year, then you can apply for a residency accreditation. And there is a list of requirements that you have to fulfill. You apply for it, they will come out and survey, and then give you your accreditation if you pass the survey. Now, the accreditation is a retroactive accreditation, so if once you're accredited, the first year residents that you graduated will be graduated from a accredited residency program. We had our site survey. We started the program in 2012. We graduated our first 2 residents in the summer, June 30th of 2013. We applied for a residency accreditation. They came out September 9th and 10th, just a couple months ago, not too long ago, for our accreditation. Before they will come out, the surveyors come out, we had to submit proof of compliance. It sounds easier than it really is. There are 7 principles and 165 standards. And the standards are national standards. They're best practice standards, and you either meet standards or you don't meet standards. There's nothing really in between. You either meet or you don't. It's pretty simple. And they really go through each one of those standards in detail, and you have to show proof of meeting the standards. So our on-site survey was a 2-day survey. They had 2 surveyors out here. They sat, they talked, they interviewed physicians, they interviewed nursing staff, they interviewed pharmacy staff, the past residents, the current residents, and all the preceptors. It was pretty intensive. And the average out of the 165 or so standards, the average number of not meeting standards is they said about anywhere between 25 and 35. You never get out of the survey without failing on one of the standards. So by the end of the survey, we had 15 minor partial compliance. And these are really minor. According to the surveyors, out of the last years of all the sites they surveyed, we had the second lowest numbers of non-compliance. So we were really happy with our results there. Post-survey, we got a written report of our non-compliance or partial compliance. And the basically minor is the policy and procedure tweaks, that type of thing that we had to fix, and we submitted back to them within 75 days. So the Commission of Credentialing, they meet twice a year, in March and August. So the March meeting is they review all programs that were surveyed between June 1st and through November 30th. So they would be meeting this March to review our data that we submitted. The August meeting, they review program survey between December 1st and May 31st. So based on the Commission of Credentialing recommendations, they will either credit your programs or they don't. And if they credit your programs, they will give you a 1-year, 3-year, or at most 6 years accreditation. So if you look at last year's statistics, there's 279 applications. About 50% of them receive a 3-year accreditation, or these are re-accreditations too. And 30% of them receive a full 6 years accreditations, which is the longest accreditations that they give. We were told unofficially that we will definitely get 3 years accreditations, more likely a 6 years, which I'll be very happy about if we get a 6 years accreditation. As far as federal funding is concerned, just like any other residency program, we can apply for federal funding to underwrite the cost of the residency program. So the program will then pay for itself. A little bit about the matching process. The American Society of Health System Pharmacists organizations set out a matching program process, which means our program is published on their websites, and the candidates will review all the programs and to see whether it matches what their goals are. They applied to our site, we interviewed them, and then after that, we submit the top candidates who we are interested in having come to our site. The candidates themselves will also rank the sites that they interviewed at. And the American Society of System Pharmacists, they will match them to make sure that our goals and the candidates and what the candidates want match. For 2012-2013, we had 40 applicants. We were a really new site. We were not on the match. It was basically through word of mouth of people knowing our program. We were not an accredited program. We had about 40 applicants, and we interviewed 12. Out of those 40, we accepted 2. So 2 candidates, we had 2 residents. In 2013 and 14, we actually had significantly more. We were part of the match program. We had 106 applicants. Actually, the first time around, we did not, when we interviewed the first set of candidates, we didn't feel like any of them really met our standards, what we're looking for. So we actually didn't rank any of them because it was better for us to pick the candidates afterwards, after the match, than to settle for 2 that we didn't really think, meets the standards we want to set. So after the match, they call it a scramble process. So all the applicants that didn't match start looking and start applying again. We had 106 applicants. We interviewed 23 applicants, and out of those, we accepted 2. A little bit about our residency program. Every residency program is different. It depends on your practice site. So our first resident was Adrian Palisak and Michelle Hsu. Some of you might have worked with them. They were here for a year. The first year, we established it in collaboration with Touro University, which is a PharmD program in Vallejo. We have a lot of their students, so we went into partnership with them to start our residency program. They do offer some training for our staff and a wealth of information and stuff like that, so we decided to partner with them. And the requirements for rotations, we look at what we have and we look at what's important for us. And the other thing too is what I'm looking for is once the residents graduate, with what type of pharmacists do I want to hire on staff? What are some of the skills they need to have to work here at Washington Hospitals? So there are 7 required rotations: orientation and operational. They need to have good, strong operational training. Pharmacy informatics. I am a big component of using the system to assist you to do the right thing, to make things easier for you to do the right thing. So pharmacy informatics is really important because in pharmacy, the way you set up the system is different based on the type of technology you have. If you have, so it's not like every pharmacy is the same. It's a combination of technology that you have within the pharmacy department really dictates how you can do things for maximum sort of patient safety. Infectious disease is important. Every patient that comes through have some form of infectious disease. Internal medicine is the standard. Emergency medicine, critical care, and oncology. We felt that these were the core things. 6 weeks rotation. The residents rotate through for 6 weeks, and this is what they focus on in that 6 weeks. Longitudinal rotations are year-round. They're going to be doing this year-round. Medication safety. Medication safety is part of all of our roles in the field. So they will work on different projects as it relates to medication safety. Pharmaceutical services, that's operational. They need to learn how to be a pharmacist as a baseline. Research project that is required for a residency program. Some of the electives, they have 2 electives that they can take where they can do another 6 weeks. Advanced infectious disease or in critical care and cardiology. And the residents also will get a teaching certificate opportunity through Touro University. And I'll talk a little bit more about that. As far as operational clinical training, for that 6 weeks, they will do, hospital orientation, completion of operational clinical competencies, IV room training. It's really important for every pharmacist to know the U.S. pharmacopoeia standards of how to prepare and have oversight of, sterile techniques. And chemotherapy, central pharmacy workflow. They need to understand, like what I was telling you about, the type of technology we have and how does that impact our workflow or how we set up our workflow based on our technology we have. And medication reconciliation, because that's an important part. Core clinical rotations, those other rotations I was talking about, the critical care, internal medicine, cardiology, all those different rotations, these are the core things that they will learn through all of those rotations. They will do all of our protocol management. We have a lot of pharmacy-run protocols. They will manage those. They round with multidisciplinary team in the critical care. Patient education, they're all required to do patient education, staffing education, nursing education, renal dosing, IBPO conversion, just the basic pharmaceutical care, and they will learn this in every rotations they do. Attend codes, precept pharmacy students, and we have weekly journal clubs and case presentations. Pharmaceutical services, and this is designed to allow residents for better understanding and development of a strong foundation of operational workflow. The residents are paired with a central pharmacist They will work. They will work in central pharmacy and do order verification to check for first doses, just really learning the operations, pharmacy operations. Research project. I can share with you the 2 research projects that our last 2 residents did. Last year, Adrian did his research project was on implementing anti-infective and comprehensive prospective antimicrobial review with clinical pharmacists. Implement an effective and comprehensive prospective antimicrobial review with clinical pharmacists. And this is working with the Antimicrobial Stewardship Committee to put together a program where the pharmacists will proactively look at the cultures and the sensitivities and the antibiotics that are being utilized, focusing on certain antibiotics, and look at the impact. Did we, what was the outcome to that? And what we found was that we had a first seasonal decrease in the overall days of therapy, of antimicrobial therapy, and increased number of pharmacist interventions. Michelle, on the other hand, works with the stroke group, and her project was on the impact of clinical pharmacist participation in post-stroke patient care in an acute care hospital. The objective is, what she had done is she actually looked at the evidence base. There's new standards that came out to update the stroke guideline and she wanted to look at the impact of pharmacist participation in post-stroke patient care. Looking at quarter ending 3/12 versus quarter ending 3/13 after the interventions. So the results is that we saw an increase in the percentage of patient meeting selected stroke core measures, specifically DVT prophylaxis and statin therapy. Medication safety, they also participate in multiple committees. The Medication Error Analysis Committee, the Pharmacy and Therapeutics Committee, they do formulary review, looking at different medication errors that we have, and do root cause analysis. These are the type of things under medication safety that they will do throughout the year. The total teaching certificate that they receive with during the residency program is they actually go up to Touro University. I'm not sure how many times throughout the year. They give a 3-hour therapeutic lecture. They lead 1 small group discussions, precept 5 clinical cases scenarios, and evaluate student programs. We have, I think, about 30 to 40 pharmacy students rotating through here throughout the years. So the residents precept them and go through disease states management with them. Some of the educational activities that our residents last year did, for the ED physicians, they gave an in-service on reversal agents for anticoagulants. They presented the research projects, and during the presentation of research project, they also educate the medical staff and the nursing staff on the latest evidence-based practice too. The guidelines are out there. Nursing, they presented their research project at the Nursing Research Council, and they also gave in-service on the guidelines update for ischemic stroke or transient ischemic attack. For RT Skills Day, the residents talked about respiratory medications, gave an overview on that. Some of the community outreach programs, they participated in the diabetes educational group and gave a talk on Straight Talk about diabetes medication. With the Minute Hearts program, they gave a talk on medical management of the heart disease. So these are some of the projects they worked on throughout the year, doing their rotations. Some of the lessons learned, I just want to share with you a little bit about that. After our first year of residency, we've really fine-tuned our screening criteria for interview process. What we did the second year around is that we actually took real case, we developed some cases, 4 or 5 cases, and as we're interviewing the candidates, we put them through these cases. If you have this patient with this disease states and these type of medications, and we went through saying, okay, we didn't give them disease states, we gave them the drugs. So based on the drugs the patients were on, what kind of disease states are you thinking that the patient have, and what will be your consideration? The next case will be, these are disease states, what kind of therapy will you be considering? And we use this as a screening criteria because the first year, we really were looking at personality. We look at what school they came from and how they did in their rotations, but we couldn't really focus on their critical thinking skills. So some of the lessons learned for the second year is we actually developed cases. And one of the cases was an impossible case. You will not have a patient that have these disease states and on these medications. And we're looking for that candidate to see, did anybody pick up that there's no way that patient can exist and is still alive? And that's how we test their critical thinking skills. The other thing is we want to identify research project early on because they really only have a year to do this, and it has to go through IRB, it has to go through approval process. They have to do the study and do the data collection. So we want to identify the research project early on. We go through evaluations of all the preceptors. We want to bring our preceptor skills through a development process. Identify potential quality improvement projects earlier on so the residents can work on them, and increase time commitment required to establish some goals, objectives throughout for the rotations. So what happened with our past residents, our 2 past residents? Adrian accepted a hybrid job as assistant professor of pharmacy practice at Touro University, and he's currently a critical care pharmacist at Alameda Hospital. Healthcare system in Highland campus. So he spent 2 days a week at Highland in the critical care areas, and he spent 2 days at Touro University teaching. He actually did, for his elective, he did an extra 6 weeks in critical care because that was his area of interest. Michelle actually moved to Detroit with her boyfriend and took a clinical pharmacist position back in Detroit. For our 2013 and 14 residents who are here tonight, Kang is undergrad. He did undergraduate at UC San Diego in biochemistry, chemistry, and minor in biology and computer science. And he received his PharmD from University of Southern California. And he did his internship at Riverside County Regional Medical Center, had a lot of inpatient experience. And Hugh is the other resident. You guys want to stand up? The residents back there. Hugh did his undergraduate at UC Berkeley in molecular environmental biology and did his PharmD at the University of Florida in Gainesville, and his internship at Tampa General Hospital. Both of them actually started here. Typically, you start July 1st. Both of them started June 15th, actually, to help us with the EPIC implementation. Hugh had help with the EPIC implementation in Florida and had a strong computer background. So we said, come on in, because we're implementing EPIC, and they both start 2 weeks early to help us through that process. It was great help. Just a little bit on the Currents. There was an article in the Currents when we finished our first residency program. We graduated our first residents. And some acknowledgement. As always, I'm sorry that Nancy's not here, because without her approval and support the whole way, this would not have happened. And I especially want to thank Ed. Ed has been there with me throughout this whole process. I remember the first time Ed tried to recruit me for the position, and I said, Ed, do you want a quality department or do you want an operational department? And guess what Ed said? Both, of course. So I just want to thank Ed. He's my biggest supporter throughout this whole time as we develop the program, the clinical program, this whole time. The other 2 people I want to thank is Kajal and Lena. Kajal is the program director, has spent hours putting the documents together. And, I really only deliver. I have the vision and the goals, and really it's my staff and my clinical coordinators who carry out my vision. So Kajal and Lena, they're clinical coordinators. They've been great through this whole thing. They developed the students program, the residency program, put everything together, and I get to stand up here and give the talk. And the other people are the preceptors. I have great staff, and you'll hear me say that over and over again. They are great preceptors, put in countless hours, because they still do their normal job. I don't give them time to precept, so they really precept above and beyond. And the hardest part when we first start out this venture is really selling the vision. I had to recruit people in and sell them the vision of developing a clinical program. And these are the people that sort of drink the Kool-Aid, actually, and came on board to help me develop the program, and with some strong leadership on the team. And our dedicated technicians. We could not have done this without the strong backbones that we have, and that's our technicians. And last but not least, our physicians and nurses. They are involved the whole way through our residency program, our clinical program, and just our pharmacy services in general. Thank you. Any questions?
Any questions from the board?
I'd just like to make a comment. It's such a beautiful thing to see the pharmacy training program come to full fruition, first with the pharmacy students and now with the development of the pharmacy residency program. One might ask, why is this important to the patients? And I think the simple answer is it can substantially improve care by having the support of top quality pharmacy personnel. We can deliver the best of care. We can look for drug interactions. We can implement protocols which provide safer and more effective care. So thank you, Mintu, for your hard work and dedication, and it's beautiful to see this get achieved. My only question is, what's next?
You know, Nancy asked me that too, because I said this year is a great year. I had 3 goals when I set out 14 years ago, and all 3 of them came to sort of fruition. My first was to start a residency program. The second is I wanted an online MAR and bedside barcoding. From a medication safety standpoint, you know, that was to have an integrated system. So we implemented Epic in July. And my third goal was to remodel the pharmacy. And that was a project I started way back through many drawings. So I'm done. I told Nancy I'm done. And
I don't
Nancy
think
said,
so.
no, you're not. What are your next 3 goals? Like, oh, man, do I have to be 65 to retire? So, you know, disease state management, preventing readmissions. If you're really talking about quality initiatives, I think we can do a lot there. And really fine-tune our residency program, our staff development, just a few.
Thank you.
Thank you again.
Thank you.
Mintu, and congratulations. It's a
Thank you.
wonderful program. I'd like now to consider a motion for the minutes, consideration of the minutes of December 11th, 16th, 23rd, 213.
So moved.
Second.
And we have a motion and a second. All in favor? of-
Aye.
Aye.
Thank you. Now we'd have some communications. Are there any oral communications this evening? Seem to be none. We'll move then to the written communications from Dr. Lunny, our Chief of Staff.
So I have the credentialing action items from December. There are no new applicants in December. For reappointments, we had Dr. Ramiro Garcia, internal medicine, Dr. Ranu Grual-Ball, radiation oncology, Dr. Kimberly Horstman, pediatric hospitalist, Dr. Aditya Jain, cardiology, Dr. Carol Kawada, OBGYN hospitalist, Dr. Padmathi Kudaravalli, internal medicine, Dr. Peter Lunny, nephrology, Dr. Maha Malakhana, pediatric hospitalist, Dr. Gregory Paranai, radiology telemedicine, Dr. Rohit Sehgal, cardiology, Dr. Shali Sinha, pediatrician, Dr. Jeffrey Thomas, neurosurgery, Dr. Shirley Sai, pediatric hospitalist, Dr. Albert Wang, internal medicine, and Dr. Jacqueline Way, orthopedics. For non-reappointments, there was Dr. Sachin Parikh, ENT, and Munet Thiel, a perfusionist. So they are deemed to have resigned. Transfers in staff category, Dr. Ramiro Garcia is going from active to courtesy staff. And finally, completion of proctorship and advancement in staff category. Doctors Farid Asfour, Dr. Li Kuo Kong, and Dr. Das Sarpel have completed their proctorship and are going from provisional courtesy to courtesy.
Thank you. Do we have a motion on that report?
So moved.
Second?
Second.
Motion and a second. Any discussion on that? There being none, all in favor?
Aye.
Aye. That motion passes. We'd like now to have our Service League report. Jeannie, it's good to have you here.
Thank you. Happy New Year to you all.
Thank you.
2013 saw 30 new adults come through the Service League, which we always love to see. So we're happy with that. Can always use more adults that want to serve in the hospital. And secondly, our annual business meeting will be Monday, February 10th. And of course, we've invited the board and hope that you'll be able to be there. It's our annual time to recognize our volunteers, especially those 4 years of service. We have 5 years, and then every 5 years, and this year actually we're going to be awarding a 40-year pin to one of our beloved volunteers. Also, there's the installation of the new incoming board members, as well as our annual gift that we get to give the hospital. So we're excited about that. Thank you.
Good. It'll be fun to meet with you.
Yeah.
It's a good group. Very, very nice group of people.
Well, that's good.
I'd like now to have our medical staff report again from Dr. Lunny.
So our medical staff currently has 506 members total, 322 of which are active, 21 are courtesy, 4 consulting, 54 are provisional active, 15 are provisional courtesy, and 66 are ambulatory. There are currently 39 applications in process, 10 in the pre-application phase, and 29 with full applications.
Busy group then with all those new ones.
Yeah, always turnover in medical staff.
Thank
But
you.
we usually maintain about 500 members.
Now we'd have our hospital calendar from Kimberly.
Yes, we'll start with the chair presenting the calendar.
Past health promotions and outreach events. On December 12th, the Washington Hospital management staff donated hundreds of presents, including bicycles, clothing, and toys, to Tri-City area families in need. The families were identified through One Child. One Child is a nonprofit organization dedicated to providing disadvantaged children with new clothing and school supplies. One Child's goal is to promote self-esteem in underprivileged children so they may appreciate their individual worth. The final Trees of Angels tree lighting ceremony for hospice care was held at Washington West on December 12th. This event featured a high school choral competition where participating high schools, including Irvington High School, James Logan High School, and Newark Memorial High School, competed for a $1,000 donation to their school's music program. The James Logan Jazz Singers won the competition. Irvington High School and Newark Memorial High School each received $500 for their participation. All of the singers received a gift certificate to McDonald's, which were donated by the Bernardin Family McDonald's. Following the choral competition, the tree was lit in the lobby of Washington West. On January 2nd, as part of the Diabetes Matters program, Diana J. Cox, registered nurse, presented New Year, New You, Setting Goals for Diabetes Success. 8 people attended. On January 7th, as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, presented Stroke Prevention and Other Disease Processes and Chronic Care and Stroke Rehabilitation, Healthy Lifestyle, Be Smart and Avoid Stroke. 8 people attended. Upcoming health promotions and community outreach events. As part of the Washington Hospital Speakers Bureau, Anna Mazet, registered dietitian, will present on healthy eating for diabetics. This presentation will be provided at the Fremont Senior Center on Friday, January 24th at 1 p.m. On Saturday, January 25th, from 10 a.m. to 1 p.m., Washington Hospital will provide the abdominal aortic aneurysm screening. These aneurysms develop over time and may have no symptoms. However, if one bursts, it can cause immediate and life-threatening symptoms. Participants undergo a Doppler study of the abdomen that is then interpreted by a physician. Fremont Bank is a sponsor for this screening. On Tuesday, January 28th, from 1 to 3 p.m., Dr. Jason Chu, pulmonologist, will present How Healthy Are Your Lungs? Latest updates in lung health and lung cancer. Washington Township Medical Foundation is a co-sponsor of this event. On Wednesday, January 29th, from 5:30 to 6:30 p.m., Nachel Bengal, registered dietitian, will present Healthy Eating for 2014. This presentation will take place at the Fremont Hills Assisted Living Facility. On February 4th from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, will present Living with Stroke and Future Diagnosis and Management. On February 5th, as part of the Speakers Bureau, Lori Roffelson, registered dietitian, will present on heart-healthy eating to employees of Boehringer Ingelheim. Located in Fremont, Boehringer Ingelheim is a manufacturer of biopharmaceutical products. On February 10th from 7 to 8:30 p.m., as part of the Washington Women's Center Evening Lecture Series, Kimberly Alvari, Director of Food and Nutrition Clinical Services, and Anna Mazet, registered dietitian, will present Meatless Monday, Get More Veggies on Your Plate. On February 11th from 1 to 3 p.m., Dr. Rohit Sehgal, cardiologist, and Lori Roffelson, registered dietitian, will present Hypertension, the Silent Killer, and Heart Healthy Meals. The Washington Hospital Healthcare Foundation Report. During the month of December, the Mission San Jose High School iKnit Club donated knit baby booties, baby caps, and scarves. The booties and caps will be donated to some of the babies born at Washington Hospital, and the scarves will be donated to patients at the Sandy Amos RN Infusion Center. Aeropostale, a national clothing retailer, donated stuffed teddy bears for the patients in the pediatric department. This is the third year in a row that Aeropostale has donated bears to Washington Hospital. The Washington Hospital Foundation thanks all those who supported the Trees of Angels tree lighting events, which raised funds for hospice care in the Washington Township Healthcare District. The Foundation extends a special thank you to all of the sponsors for Trees of Angels, including Fremont Bank, Gonzalez & Kozenchenko, and Fried & Associates. Special recognition is due to presenting sponsor Mark Bernardin of Bernardin Family McDonald's, who has supported Trees of Angels since its inception 18 years ago. The Washington Township Healthcare District Board of Directors report. In the past month, District Board members represented Washington Township Healthcare District at the Trees of Angels tree lighting events and the Newark Chamber of Commerce Holiday Mixer. Washington Hospital Employee Association, WIA. WIA hosted the Children's Holiday Party. The event featured a live-action book reading by The Grinch Who Stole Christmas, as well as a sing-along with Rudolph the Red-Nosed Reindeer and Frosty the Snowman. The children and families also enjoyed a photo with Santa and Mrs. Claus. Over 120 people attended. In the spirit of giving, WIA donated gift cards from Target, Payless Shoe Source, Safeway, and other local stores to homeless families living in the shelters at Save and Abode Services. The gift cards will allow families to purchase food and clothing. A total of $1,475 in gift cards were collected and divided between the two organizations. Washington on Wheels, WOW, Mobile Health Clinic. During the month of December, the Washington on Wheels Mobile Health Clinic, WOW, provided primary health care services to community members at the Fremont Family Resource Center, the Silliman Activity Center in Newark, and the Ruggieri Senior Center in Union City. WOW also provided services to students at Breyer Elementary School in Fremont. WOW provided occupational health services, including TB testing, to 33 employees of the Newark Unified School District and 20 flu vaccinations to employees of Carrie Sweet Ingredients. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was December's most viewed webpage with 13,091 views. InHealth, Channel 78. During the month of December, Washington Hospital's cable channel 78, InHealth, aired new programming, including a Washington Women's Center program, Healthy Holiday Cookies, and the December Board of Directors meeting. InHealth also taped a Diabetes Matters program, Strategies for Support, Coping with Chronic Illness During the Holidays. Protect yourself from the flu. Many states across the country are reporting widespread flu activity. Additional increases are expected in the coming weeks. If you have not received your flu vaccination this season, you should get one now. A flu vaccine is the first and best way to protect yourself and the people around you from influenza and its potentially serious complications. H1N1 has been the predominant circulating virus so far. During the 2009 pandemic, H1N1 caused more illness in children and young adults than in older adults. The pandemic also was noted for reports of severe illness among pregnant women. The CDC recommends annual influenza vaccination for everyone 6 months and older. Anyone who has not yet been vaccinated this season should get an influenza vaccine now. The risk of severe disease and complications from influenza is higher among children younger than 5 years of age, adults age 65 and older, pregnant women, and those with underlying medical conditions. Washington Hospital is hosting 2 flu clinics in the month of January. They will take place on Thursday, January 16th and Friday, January 17th from noon to 2 p.m. and again from 3:30 to 5:30 p.m. in the lobby of the Washington West Building. The flu shots will be offered at a reduced rate of $10 per person, cash or check, and the vaccine is available to those who are 4 years or older. Flu vaccinations are also available at Washington Urgent Care. The clinic is open 7 days a week from 8 a.m. to 8 p.m. and no appointment is needed. For more information on any of these programs mentioned, visit WHHS.com or call 1-800-963-7070.
Before moving on to Employee of the Month, I just wanted to reiterate that we are seeing more cases of H1N1 here in the hospital through our emergency department, and also seeing an increase in respiratory diseases coming through Washington Urgent Care, our urgent care clinic here in Washington West. I think we've been hearing in the news that officials are saying this is really just the beginning of the flu season, and the numbers are relatively small here in California, but they're expected to increase, and really trying to put the word out, the importance of getting vaccinated and also taking precautions, hand washing and other precautions that need to be taken. I think we've seen that so far that there were 4 people that have died. It's mainly been hitting people under the age of 65, but 2 of those cases were in Contra Costa and 1 in Santa Clara. So again, we're trying to get the word out in terms of our flu vaccination clinics, and also the precautions that need to be taken, especially around hand washing too. So I want to make sure people are aware of that. Moving on to our Employee of the Month for January 2014, it's Christy Schubach. Christy is one of our most knowledgeable and skillful team members in our critical care unit. She has been employed with Washington Hospital since 1999 as a per diem night shift nurse. She has her critical care nurse certification and is one of the few nurses who has been both a cardiac medical and a cardiac surgical certified. She stays up to date with the latest evidence-based practices, which she shares with her staff. She has a strong work ethic and is highly respected by the physicians and her peers. At the bedside, she is compassionate and raises the bar in the quality of care she gives to her patients and families. Christy is versatile and flexible and has cross-trained in the emergency department and has been of tremendous help to emergency room staff as well. Christy has been instrumental in keeping the ICU organized and stocked. She volunteered and spent countless hours with her storeroom staff to make sure all of the ICU supplies were labeled and categorized in its proper drawers and areas. She has also worked with our intensivists and other physicians to ensure they have supplies they need in the unit. During the winter months, Christy loves to ski. She enjoys watching ice hockey as well. She also has a love for animals, especially cats and dogs. So, happy to present Christy for January 2014. Thank you.
Thank you. Next item is a construction report from Ed Fayan, our Senior Associate Administrator.
Thank you, Dr. Stewart. So if I'm back up here, it must mean that we're going into the new phase of construction, which we are. So I thought I'd give an update, just to sort of set the groundwork for what's coming in the immediate future. So this schedule, the main things I want to point out is next week we start the asbestos abatement in the Whitaker Pavilion, and that will take about a month. Starting the next day, we'll go to the bidding process for the demolition of the Whitaker Pavilion, and then start that work the first week of March. And so that's our schedule there. On the building itself, we anticipate we're still going through drawing changes due to value engineering and comments from the contractor since he came on, so we had to do a whole new set of drawings off of that. We anticipate that being done the end of January, and then we anticipate getting bids from 70% of the subcontractors on this. All the 70%, this contractor is responsible for 70% of the work on April 2nd, between April 2nd and April 30th, and then start work on the Morris Hyman Pavilion on May 1st of this year. Now, in the meantime, and maybe more importantly, we're working on the garage. And the garage, we run into a few bumps in the road on the garage. You might remember that about 4 years ago we did an EIR, and we included, that was specifically for the rest of the buildings in this master plan. The CJR and the central plant were grandfathered and did not need an EIR, but these next two buildings did. And all that information was presented to a variety of publics, including the city of Fremont, and then we took those comments, included it in our EIR, and they're incorporated in all our documents for construction. But all parties had an opportunity to make a comment on those. That was followed up after the EIR. We have been actively involved with the city of Fremont on their planning for their new city center, which is going to be off of Capitol, is going to be the main thoroughfare for that. And there was a lot of discussion about city center and the tie-ins between BART and the Capitol Avenue. And so we have been involved in those planning meetings, and actually out of those meetings, that was the catalyst for us sitting with BART and talking with BART about how we could develop the garage to include our needs, utilize some of BART property, and also give BART what they needed, which was space for their BART police at the Fremont station. And that was all vetted in the planning sessions with the city of Fremont. And actually, I think everybody was pleased that we were able to come to agreement and move forward with this. In the meantime, we have met 2 to 3 times with city construction people to go over our plans as we are developing them, because we have been working all this year in getting a plan for the garage, and actually have just recently finished that plan and submitted it for permitting. When we submitted it for permitting, we got the usual request for permitting fees, which we submitted, which was followed by another request for fees in excess, for $50,000 for review of our plans, which we hadn't been asked for before in any of our projects that we've taken through the city. So this is a new thing that we had to sort of vet with them and talk about. And I understand that before it's over, we'll be requested for about $100,000 worth of permits for the garage. And then once we submitted the $50,000 check after we vetted it and saw that that was what we had to do, there were no other options. Within a week, we got a notification that our plans have to go before a separate committee from the permitting department for plan review and, let's say, architectural review. So we just have started that process. We said, gee, gosh, we've been meeting for for the last year on a variety of things and bringing you up to speed with where we are. And we've finished our design documents. Isn't it a little late for us to be going through an architectural review? And they responded that, yes, that's true. They should have brought that up earlier. And they'll go through this process while we're going through the permitting process. And they state to us that it'll be expedited and that we should get done with both of them, we anticipate, by April. But stay tuned. That's kind of where we are. Now, the garage issue is important. I'll go into the plans here in a minute, but as I'll soon show, there's two things. There's parking that's going to be impacted to a large extent, and then we've got the helipad there that also is going to be impacted by the construction that goes on. So delays in the garage are going to be problematic for us. So we want to make sure that that stays on track, but that's sort of the developments that have occurred here in the last 3 months. Without further ado, I'll go a little bit into where we are and what's happening and what you should anticipate. So you'll remember this slide. It was a flyer that I think was distributed as an information about our master plan. You'll notice the two buildings in blue are the garage and the Hyman Pavilion, and of course they are our phase 2. This is the footprint for these two projects. If you compare them to the CJR and the central plant, you'll see that it's about 3 times the size, just physically, of those projects, and it's about 3 times the size in terms of dollars. So these next projects are extremely large. The last one we did was the biggest in terms of expense for the district. Obviously, these are going to be even larger by a significant margin. So we've got a large portion of the campus that's going to be affected. This gives you a little bit of idea of the existing buildings that are going to be replaced. So here you can see the Whitaker building and the pavilion and the Fast Track building all get demolished either at the beginning or in the process of this construction project. And the new Hyman Pavilion basically goes on that footprint. This is the access, and this road will be included in that for the emergency department, which is located here. So you can see it's going to be constricted in terms of our space here. We're going to have to put in valet parking and various things that we can keep people getting into the facility and getting people parked away from this vicinity, which of course has ambulance traffic as well as drive-in traffic. This is basically what we call the laydown area. So for the contractors with all their equipment, with their buildings, there's already a little encampment out here of new buildings for the general contractor. During the project, we're going to be keeping the helipad open, and the plan is to keep it open as long as possible. For the first year, of course, we're going to be there's a lot of work that's going on underground. There's the whole excavation that has to go in. As you know, this is base isolation, so there's a sub-basement, there's base isolators that have to be put in, and then a basement on top of that. So there's a lot of work going on underground, which in the plan is for this building back here, this building that's not shown there, but in that space, the garage to be built. And so we can take some overlap, but you've got cranes and things like this as you're putting up a 3-story building on top of the garage of the 2 sub floors. We would like to be away from that area with that helipad. Though if we have to overlap some, we have plans to be able to do that. So this gives you an idea of the work area. This area back here is a combination of the work site for the garage and also the laydown area for that contractor, who will be separate from the Phase 2 building. As you can see, in terms of parking, this is all our employee parking back here, all this space, and basically it all goes away. So we have some arrangements for parking to be off-site. We'll have to make a few more by the time we're in this full-blown. And obviously, we're going to want to have that garage come on as quickly as possible so that people have convenient parking. This gives you a shot of the new garage building as designed now and as has been reviewed up to the permitting process with the City of Fremont. You can see the helipad on the top of the building, close, sort of aligned with the Hyman Pavilion. This gives you a southward facing, excuse me, this gives you on the west side looking at it, looking east. This is a southward facing view of the building. And so these are the next two steps of the master plan. So I wanted to give you sort of an update. Any questions I can answer for you.
No questions from the board? Thank you, Ed.
Thank you.
Nice to see that moving forward. It's too bad we're slowed down a little bit. We'll now have our quality report from Barbara Eusebio.
Okay, thank you. Thank you, Dr. Stewart, and good evening, all. Tonight, I'm going to talk about our national patient safety goals. I guess I had my eyes operated on, so now I guess I don't need glasses anymore. Can actually see the screen. For 2014. So the National Patient Safety Goals were established by Joint Commission in 2002. So these, you should be fairly familiar with these. They did these, to help accredited organizations address areas of concern in patient safety. And the first set actually went into effect in January 1st of 2003. Joint Commission used the Patient Safety Advisory Group to help them develop these goals. This group is a panel of recognized safety experts throughout the nation. There's probably, I looked at it today, and there's probably about 20 individuals on that panel from various areas of healthcare. So they do give advice on what they think the goals should be. We have a patient safety committee here at Washington Hospital, and members of our committee include personnel from infection control, nursing, pharmacy, quality and resource management, compliance, medication safety, physical therapy, facilities, and medical staff. The responsibilities of the Patient Safety Committee include developing a proactive risk reduction strategy. We review reports and events. We look at data and analyze them and come up with performance improvement strategies. We do an annual assessment of potential safety risks, and we try very hard to foster a learning environment, encourage identification and reporting of errors. The current state of patient safety in the nation is that there still is a variation of quality of care throughout the nation, and there still is continued preventable errors in all-cause readmissions. Those seem to be two of the top areas that we, not only us, but the nation is trying to improve. Other top nationally reported adverse events for 2013 are medication errors, hospital-acquired infections, serious injuries and accidental deaths, communication and diagnostic errors. So the current measures and updates for the calendar year 2014 are patient identification, medication safety, staff communication, healthcare-associated infections, patient safety risks, surgery risks, and emergency preparedness, which is a new addition in 2014. So to improve the accuracy of patient identification is the first goal. Joint Commission and CMS expects us to improve the accuracy of patient identification with the use of at least 2 methods of identifying the patient. So typically, if you've been a patient, you've probably heard several times, what's your name and date of birth? Those are the 2 typical ways to identify a patient, ensure that they have the right medication and the right treatment. And they really want us to focus on eliminating transfusion errors this year, and avoid patient misidentification. Second goal, improve effectiveness of communication among caregivers. We provide the responsible caregiver the critical results when an established time frame, so prompt treatment can be provided. Hospitals have to designate or determine what are our critical tests. So what would be a critical test? Somebody had an x-ray done and they had a punctured lung. That would be fairly critical. The doctor would want to know that quickly. So this patient safety goal allows us to put a process in place where the designated critical tests are then reported quickly to a nurse or to a physician, and we go up the chain of command if we have to within 30 minutes or so to get that reported. Medication safety, the goal to improve safety of using medications. Sometimes medication is taken out of their original container and put into an unlabeled container, particularly on a surgery field. And we have to ensure that when that is put into an unlabeled container, that a label is put on that container and then not put on the surgery field. So that's very important. We also have to take very extra care with patients who are on blood thinners and maintain and communicate accurate patient medication information, as well as reconcile our medications at discharge, meaning that we have the correct list of medications, but that the patient came in with, and we reconcile that with the medications that the patients are going home with. Prevent the spread of healthcare-associated infections. I think you've heard me talk about these quite a bit in the last few months, so this is no surprise that we have to continue to reduce our hospital-acquired infections, such as our C. diff and central line infections, surgical infections, and urinary tract infections. Identify safety risks inherent in the patient population to protect at-risk patients. Conduct a risk assessment, and they're looking for patients who have a suicide ideation or suicide plan. They really want us to be assessing for that and addressing those safety needs immediately and making sure that they're putting in the appropriate treatment area. Conducting the correct procedure at the correct site with the correct person. This is nothing new. This is in the pre-procedure verification process, where the surgeon comes in and marks the site, the surgical site. There's a timeout that's done before surgery and all procedures. Improve the safety of clinical alarms. This is actually our new emergency preparedness goal. What they would like us to do is to establish a list of our critical clinical alarms in the organization and ensure that they are working properly, that we know how to test them. We need to determine how audible they can be, and they have to be tested on a regular basis. That assessment is for this year, and then in 2016, they are going to expect us to develop and implement specific components of policies and procedures, and also educate about the alarm system management is also required. If you've ever been a patient or you visited a patient, particularly in a critical care unit, you hear a lot of alarms go off. And across the nation with practitioners and providers, there's been what's called alarm fatigue. So after a while, you stop hearing those alarms, and that's what Joint Commission is worried about. They want to make sure that our critical alarms are at an audible level and that they are attended to quickly. So all hospitals receiving accreditation from Joint Commission must implement with these national patient safety goal requirements in an effort to maintain safe environments and provide quality of care to all of our patients. Questions? That's my goal for the year.
Only that.
Lot to do this year. We're in our Joint Commission window, so we expect them to be arriving sometime, probably spring.
Good. Any other questions from the board? Thank you, Barbara.
Okay, you're
Nice to
welcome.
be updated on all those things.
Thank you.
We're now ready for our finance report from Chris Henry, our Chief Financial Officer. Chris?
Okay, so tonight we will be reviewing the operations and financial results for November 2013. As we reported to you last month, our census numbers were down, continued to be down in November. Average daily census for November was 153. We had expected 168.1. Admissions came in at 919, 50 below the budget of 969. Patient days, likewise, were below budget at 4,609. We had expected 5,043 for November. Outpatient observation days continued to be down as well in November. We saw 223 outpatient observation days. We had expected 338, which is where we had been running pretty much consistently for the prior year. Average length of stay for the month came in a little bit below budget at 5.04. We expected 5.2. Looking at utilization, case mix index for the month came up a bit from the prior month at 1.494, but below the budget of 1.537. We had 142 deliveries in November. We'd expected 164. Surgical cases were 75 below budget in the month at 329. That includes our joint replacement cases that were 18 below budget at 106, neurosurgical cases that were 12 below budget at 9, and cardiac surgical cases that were 9 below budget at, that were 9 below budget at 5. PTCA procedures for the month were 13 below budget at 29. Our total cath lab activity for the month was 345 cases. We expected 433, so the cath lab was way down as well. Outpatient visits for the month likewise were below budget at 7,110. And the emergency room, actually one of the lower levels of activity that we've seen in a while at 3,949 visits. We expected 4,178. Looking at productivity, productive FTEs for the month came in 21 below budget at 1,251. We had 168.3 non-productive FTEs for the month, giving us total FTEs that were 49.4 below budget at 1,419. Our FTEs per adjusted occupied bed a little bit above the budget. With this low level of activity, we've really been working to flex these down, but we ended up at 6.94. We expected 6.65 for the month. And moving into the financials, as you would expect, this lower level activity resulted in a less than expected financial performance. Total patient revenue came in 11.8% below the budget at $157,069,000. Our contractuals for the month came in a little lower than anticipated at 76.38. So we ended the month with net operating revenue about 10.6% below budget, or $4.4 million, at $37,342,000. Operating expenses for the month came in about a little bit over $2.9 million below budget at $38,978,000. The big drivers there were our salaries and wages with our lower FTEs. Benefits were about $500,000 below budget in the month. We did see a lower level of the high dollar claims we had been experiencing over the last several months. Supplies came in about $825,000 below budget, largely driven by the volume. And our purchase services and pro fees came in a little less than $500,000 below budget as we really tried to crank down on those things with our lower level of activity. Likewise, bad debt came in line with our gross revenue, about 11.9% below budget at $5,363,000. So we end the month with an operating loss of about a little over $1.6 million. We had really expected pretty close to a break-even month in November. Non-operating loss for the month came in at $548,000. Of note this month, we did do the first issuance of our general obligation bonds to fund the construction activity that Ed discussed a little earlier. There's a new accounting rule this year. In the past, those bond issuance costs would have been amortized over the life of the bonds. New accounting rules now require us to recognize it in the month that they are incurred. So we did have an additional $1,442,000 added to our non-operating results in the month. So we ended November with a total operating loss of almost $2.2 million. We had expected a loss of about $436,000, including that bond issuance cost number. Quick look at our FASB format. This is the way the financial markets might look at us. As always, our operating bottom line stays the same with a $1.6 million loss. We do remove our our tax revenue that supports our GO bonds and our unrealized gains or losses in our investments. So we end the month of November with non-operating loss from a FASB perspective of $943,000 and a total bottom line a bit over $2.5 million loss from a FASB perspective. So are there any questions on November?
None.
Okay.
We can move now to our operations report. Kimberly?
I will give the statistics for the month of December 2013. The month of December saw 1,010 patient admissions that resulted in an average daily census of 167. This is 4.2% lower than the budget of 1,054 admissions and 5.5% below the budgeted average daily census of 177. December's average daily census is or was the highest we had experienced at this point in fiscal year 2014. An increase in medical patient admissions and patient days in December was offset by inpatient surgical and cath lab volumes that were lower than budget expectations. Outpatient observation equivalent days of 248 were lower than the budget of 321 by 22.7% and were lower than December 2012 by 11.1%. The average length of stay based on discharges for adults and children in December were lower than budgeted at 4.84. The budget anticipated an average length of stay of 5.20. This lower length of stay is attributed to inpatient cath lab being lower, cardiac and neurosurgical volumes also being lower, which typically result in longer lengths of stay. Moving on to births, the birthing center saw 136 deliveries in December compared to the budget of 160. Deliveries in December resulted in 268 baby days. Newborns totaled 137 in the month. For the month of December, there were 348 surgical cases, 4.7% below the budget of 365. This includes cardiac surgical cases that were 5 below budget, neurosurgical cases that were 5 below budget, and joint replacement cases that were 3 above budget. Inpatient surgical activity overall was below budget by 11.6%, while outpatient surgeries were above budget by 28.6%. There were 618 cases were seen in the outpatient surgery center versus a budget of 613. For the month of December, total cases in the cath lab were 317 versus a budget of 399. This includes PTCAs that were 7 below budget, cardiac cath procedures that were 36 below budget, and interventional radiology procedures that were 22% below budget, 22 cases below budget. Overall, inpatient cath lab procedures were 66, less than anticipated, while outpatient procedures were 16, or 8.5% less than expected. Moving on to non-emergency outpatient visits. Outpatient visits for the month of December of 7,101 cases were 672, or 8.6% lower than the budget of 7,773. This included clinical lab visits that were below budget, offset by higher than expected X-ray visits. Other favorable volume budget variances were noted in the infusion center and also diabetes education. The emergency room recorded a total of 4,243 patients, average daily census of 137, which 119, 2.7% below the budget of $4,362. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,509 patients during December, 59 less than the budget of 3,568. Total system emergency room and clinic visits for December were 7,752 compared to a budget of 7,930 visits. Full-time equivalents for the month of December totaled 1,425.2, including 13.6 agency personnel. This was 71.7 lower than the budget of 1,496.9 FTEs. The FTEs per adjusted occupied bed were at 6.50, which is below the budget of 6.57. As Chris referenced, staff have been working hard in terms of flexing with the volume. Productive FTEs were below budget also by 69.8 for the month. Non-productive FTEs for December were below the budget by 1.9 FTEs. Patient mix preliminary information indicates that inpatient revenue for the month of December amounted to approximately $131.6 million compared to the budgeted estimate of $143.2 million. Of this amount, 58.9% was Medicare, including Medicare HMO, and 17% was Medi-Cal, including Medi-Cal HMO. This compares with the budgeted inpatient revenue percentages of 56.1% Medicare-sponsored patients and 16.6% Medi-Cal-sponsored patients. Total government program revenue for December was 75.9% of total inpatient revenue versus the budgeted of 72.7%. Inpatient revenue for the month was under budget by $11.5 million or 8%. This is attributable to the lower census and procedure volume, which also drove down lower ancillary service and volume and supply revenues. Outpatient revenue for December was above budget by $258,000 or 0.6%. So in summary, December had 44 fewer admissions and 305 fewer inpatient days than anticipated in the budget. Surgical cases were below budget by 17, and cath lab procedures were below budget by 82 for the month of December. Outpatient visits for December were 672 or 8.6% below budget, while the ER visits were 119 or 2.7% lower than anticipated. Clinics visits for the month were below budget by 59 or 1.7%. Total paid FTEs are below the budget by 71.7 or 4.8% for the month and below the last 12 months average of 1,454.3 by 29.1 FTEs. FTEs per adjusted occupied bed were also below budget. Inpatient charges for the month were lower than budget by approximately 8%. Outpatient charges were higher than budget by approximately 0.6%. Total hospital charges for December were below budget by approximately 6.1%. On December 31st, there were 155 days cash on hand. The total days revenue and accounts receivable at December 31st was 70.2. The days revenue and accounts receivable, excluding Medi-Cal, was 66.5. During the month of December, 2,791,566 of charges was approved or pending for charity assistance. We should note this is the highest level of charity care that we have seen over the last 12 months. On average, we've run about 2,179,000. So those are the statistics for December.
Thank you. Thank you, Chris. This time we're ready to take up our action items for the evening. Mr. Wallace will present those. Action item A.
Mr. President, I move for the reappointment of Ben Saw, MD, Shirley Bushke, James Stone, Russ Blowers, and Miro Garcia to the Washington Hospital Development Corporation Board of Directors for 2014.
Second.
We have a motion and a second. Is there any discussion on that? I find these people to be excellent, wonderful people. Very, very dedicated and very anxious to do whatever they can for the good of the hospital. All in favor of that motion?
Aye.
Aye. That motion passes. Item B we have taken care of. That was earlier, the commendation for Christine. We'll move now to item B, C.
Item C. Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts to proceed with the build and implementation services for the ICD-10 project for a total amount not to exceed $7,396,400. This project was included in the fiscal year 2013-2014 capital project budget.
Second.
We have a motion and a second. Kimberly, if you'd like to explain that a little further, that'd be nice.
Sure. I think the board has received a couple of presentations on ICD-10, the latest one by Julie Green. The hospital currently uses the the ICD-9 system to code all patient diagnoses, procedures, and treatments in order to bill third-party payers. And starting, as we've talked about, in October of 2014, Centers for Medicare and Medicaid Service requires hospitals and physicians to submit their bills coded with this new system, this ICD-10 system, which basically breaks down diagnoses, procedures, and treatments to a much greater level of detail than in the previous way that we've billed. The EPIC system, which Washington Hospital installed in July of 2013, is capable of assigning ICD-10 codes to diagnoses, procedures, and treatments. However, the system was built with ICD-9 codes, because currently that is how we're billing, and has to be rebuilt. The ICD-10 project will rebuild all of the diagnoses, procedures, and treatments so that the appropriate ICD-10 codes are assigned. It will also develop physician smart phrases and order sets so that documentation supports this more comprehensive and detailed coding system. And I think we've seen some of those coding books and how thick they are of all the new codes. So, as mentioned, this is a budgeted item.
And a frustrating one.
Yes, I agree.
All in favor of that motion?
Aye.
Aye. That motion passes. Item D.
Mr. President, in accordance with district law, policies, and procedures, I move for approval of resolution number 1143, authorizing employer pickup of employee contributions.
Second.
A motion and a second on that. Kimberly, do you have any comments on that? for the
Right.
public?
This is another requirement as a result of the California Public Employees Pension Reform Act of 2013, otherwise known as PEPRA. Employees of the district with hire dates after January 1st, 2013 must contribute 50% of the normal cost of their pension to the Washington Township Healthcare District Retirement Plan. So based on extensive conversations with our legal counsel, Benefits Legal Counsel, we recommend that the contributions made by the employees be considered as pre-tax. The Internal Revenue Service allows the treatment of the employee contribution to be considered pre-tax as if it were made by the employer if a pickup provision is enacted. In order to enact the pre-tax status for the contribution, the Internal Revenue Service requires a board resolution for this pickup specification, and this is what you would be considering here tonight.
I think that's a wonderful thing that the hospital has offered employees. It could be very, very difficult for someone to be caught in that situation.
Right, so as I said, it's something that's mandated now for us, but we're trying to work through these pieces of it.
Is there any other discussion on that? All in favor? Aye. That motion passes. Now, the next item is item E, and before we take that up, I'd like to make a few comments on that myself. This item E, involves the Chief Executive Officer's employment agreement. The Chief Executive Officer is the only employee of the district who is hired directly by the board. Annually, we review the CEO's performance as required in the employment agreement. As part of our annual process, we consider data provided to us from independent consultants and any and all other factors we consider important. This is then considered by the board in determining whether or not base salary should be adjusted or whether we should make an award of incentive compensation. Also, at this time, we consider whether we should make any revisions to the Chief Executive Officer's employment agreement. At the outset, let me explain that this past year has been a very challenging year for the district from the standpoint of continued downward pressures on revenues and the uncertainties regarding the Affordable Care Act. While we can take some solace in knowing that we are not alone, other local institutions and even other institutions like the world-renowned Cleveland Clinic are suffering the same downward pressure on revenues in the uncertain environment of the Affordable Care Act. We cannot be passive as we try to survive in the increasingly stormy climate that is healthcare in the United States. We saw that tonight in our latest financial report. The Affordable Care Act provides us with many challenges. To say the least, the implementation has not been smooth. While this has been a boon to the talking heads on our news shows, the hard truth is that the rocky implementation is adversely affecting individuals, including many residents of our district. I do not think that anyone really knows where we're going to end up on all this. The rules seem to change almost daily. The second major challenge of the Affordable Care Act is the definition that affordable hinges on one thing, and that is cutting reimbursements to hospitals and physicians. Now, I think we can all agree that the old system needed improvement. However, the notion that millions of dollars can suddenly be cut from reimbursements that we have normally relied upon, that presents a huge challenge which cannot be solved overnight. They certainly can't be solved when the rules keep changing almost daily. Not surprisingly, our financial performance has suffered. But so has the financial performance of many other healthcare providers, as previously mentioned, the Cleveland Clinic. Nevertheless, the mission of the Washington healthcare system remains the same. We desire, above all, to provide high-quality healthcare to our residents and patients. This board has consistently said that it is dedicated to that mission. As we transition to a new but uncertain reality, we need experienced leadership at all levels of our hospital, especially the level of our CEO. The most significant achievement of the past year was our relationship with UCSF. For us, this is a singularly historic achievement. UCSF is a world-renowned academic medical center. By virtue of this affiliation, we open the door to access to UCSF both for our patients and our physicians. While that achievement was a team effort of the hospital, there is no doubt that the idea to pursue this affiliation and the final realization of this affiliation was largely due to the efforts of Nancy Farber. Another significant achievement was the implementation of EPIC, the electronic health record system. This was and continues to be a monumental undertaking. By the way, regardless of how one may feel about the need to move from paper to electronic records, federal law provides an incentive to move to that record, and it also provides a strong disincentive in the form of further reduced reimbursements if we don't do that. We really have no choice, and we've moved ahead with that aggressively. More important than that even is that UCSF and many other hospitals in the Bay Area are on the EPIC system. A third major accomplishment in this last year is the continued success of our joint research of the Institute for Joint Restoration and Research. That particular area of our hospital has been extremely successful, being recognized as the #1 joint replacement center in the Bay Area and the 4th best in California. U.S. News and World Report also gave the hospital a wonderful report by listing us as the 4th best overall hospital in the Bay Area. Included in that were many of our specialties: diabetes, neurology, gynecology, and safety. Those are tremendous achievements by the hospital in difficult times. We are also in the midst, as Ed has shown us tonight, in the midst of a massive facility master plan, which will provide vastly expanded and a modern emergency room and critical care unit. This will bring key facilities of the hospital into the 21st century. So when you look at this very difficult environment we're in and the tremendous challenges we have ahead of us, the district has nevertheless made some positive steps, and this has been the result of the leadership of our CEO. Although Washington Township Healthcare District is a public entity, we are a district hospital, finally defined as a public entity. We are very much different from other similar types of public entities like cities and counties and other districts. We do not receive any taxpayer funds to cover operations. The district is required, in addition to all these other challenges, to compete against other hospitals for patients, to compete against profit and nonprofit healthcare providers to cover our operational costs. Our operational costs include salaries, and those salaries are not coming from any taxpayer funds. An analysis of our CEO's compensation award, whether in the form of base salary or at-risk award, must be done in the context of a market of similar CEOs in similar organizations. We cannot, under any circumstances, compare our hospital to other public entities. It's simply unfair. We're comparing apples to oranges. I want the public to know that this issue, the issue of our salary to our CEO, is a very, very challenging issue for the board. It's difficult for all of us. There is a perception out in the world that public employees should be arbitrarily limited to some number that does not reflect the real market. Yet to do so is not rational nor reasonable in the circumstances of our hospital. We must operate on a different basis than other public agencies. We must meet market costs, or the quality of our employees, the quality of our leadership will suffer greatly. I think our CEO deserves a raise, and she probably deserves a raise higher than we can at this time allow. But I would suggest at this time a raise in the 4% range. With regard to the at-risk compensation, I would suggest an award of 25% of the maximum possible 40%. I suggest that number because it is a little higher than the midpoint, but not the highest possible, as we have to balance an award based on our overall finances. In summary, I believe our CEO is doing an excellent job in light of unprecedented challenges in the healthcare industry. She was crucial for a critical, almost foundational relationship to occur with UCSF. I can't overstate what that achievement can accomplish for our hospital in the future. I also believe that we have a CEO who has many, many years of experience, greatly talented, and I can't imagine a better situation for the coming challenges that are ahead of us. in light of her performance, I suggest that we also extend her contract by 1 year, consistent with our prior practices. Those are my feelings on it. Before I entertain a motion or board discussion on that, I'd like to open this up for any public comment that might be made at this meeting today. If there's anyone in the audience who would like to make a comment on this, we'd entertain that at this point. Seeing none, the public hearing on this subject is now closed, and I would now like to refer it to the board for a possible motion. If any of those board members agree with my presentation here, I'd welcome a motion on that item.
Well, Mr. President, just to start the discussion going tonight, I'll recommend a motion. So, in accordance with district law, policies and procedures, I move that, number one, the employment agreement between Washington Township Healthcare District and Nancy Farber, CEO, be amended to increase the base salary by 4% effective November 1, 2013. And item two, that based on the performance of the CEO, the board award Nancy Farber, CEO, at-risk performance compensation of 25% of base salary, which equals $162,783.25 to be paid forthwith. And item three, that the employment agreement between Washington Township Healthcare District and Nancy Farber, CEO, be extended by 1 year for a new term beginning November 1, 2013, and ending October 31st, 2017. And further, that the President of the Board is hereby authorized to execute the appropriate form of amendment to accomplish the actions taken by the Board here tonight.
Mr. President, I second that.
Thank you, Dr. Nicholson. I'd invite other board members to comment on this. It'd be good to have a discussion on this very sensitive and important issue.
I think that it's important that the public realizes that the operations of the hospital annually cost nearly $500 million. So $500 million is the amount of money that's being managed by Ms. Farber and her management team, and that is no small sum of money. I think the public should also be reminded that in the past, the healthcare in this country has been pretty much a cost-shifting model prior to the Affordable Care Act, and in reality, it still is. And by cost-shifting, I think most people understand that with the passage of the COBRA and EMTALA legislation many, many, many years ago, it has been possible for folks who are totally uninsured, even those who can afford insurance, to come to healthcare providers such as a hospital and have their needs taken care of, and without compensation to the hospital in many instances. And that reality was funded by many procedures that the hospital did. So for folks that had insurance or the means to pay for the procedures. This was a robbing Peter to pay Paul model that has been going on for decades. And this is the major, in my opinion, effort of the Affordable Care Act, also known as Obamacare for those in the public that don't know what I'm talking about, to address and thereby more evenly spread the cost of health care across the entire population. What we are caught up in at the moment is a transition from the robbing Peter to pay Paul model, or the cost-shifting model, to a situation where Peter is getting hammered. The funds that would come to the healthcare providers, such as doctors and hospitals, for performing services for Peter are dwindling, and Paul is still in there needing services. And I think Kimberly mentioned tonight, the enormous amount of charity care and uncompensated care that is continuing and is growing, and at the same time, our revenue is declining because Peter is getting less and less funding. And so that's the transition that all the hospitals in this country are now facing. And but we are in the reality, at the same time this is happening, have to manage a $500 million annual outlay at a time when the funds that normally go to Peter for Peter's care in the revenue line are diminishing. But the $500 million is not going away, and it has to be managed. And it takes a lot of talent to manage that type of an outlay annually. So I am totally in favor of the numbers that you have suggested with respect to the salary change and the incentive award.
Thank you. Dr. Nicholson?
Thank you, Dr. Stewart. I think you've expressed a lot of my thoughts already in your opening remarks, but just to reiterate, 2013 has been a very challenging year, and 2014 will be ever more so. The healthcare environment is presently characterized by tremendous amounts of uncertainty, decreasing reimbursements, increasing unfunded mandates, as we've seen on our agenda tonight with the ICD-10 $7 million implementation costs. In addition to that, we've had a struggling economy and issues such as a government shutdown, which we've had to contend with as a country. So this represents a challenging environment for a hospital to operate within. Clearly, there's downward pressure on our top line, our revenues coming in from insurance companies and payments from patients. This will continue, as Mr. Wallace alluded to earlier. The bottom line is that we need to have experienced, talented, competent leadership which is in tune with what is happening in our immediate environment and within our hospital. And I think we have that, and I think it's important to retain that. Despite the challenges that we've had over 2013, I think we've seen some tremendous accomplishments. As you mentioned, Dr. Stewart, the affiliation with UCSF, a plant which is beginning to grow, and as the years progress will yield great fruits. I think as the presentation that Mintu Denon, our pharmacy director, showed tonight, that being part of a teaching institution has tremendous benefit to a facility. UCSF affiliation will offer that opportunity in the years ahead. The second huge accomplishment was the implementation of the EPIC electronic medical record. Challenging as it is, it's going to yield great benefits as far as improving the quality of care and improving our ability to deliver care more efficiently and effectively and safely. So those are the two great accomplishments that I've seen. In addition, we've had numerous awards and recognitions of the quality and performance of our many great programs. So this is all the result of top quality leadership, and I think this is what Nancy has led us over the years to be able to bring together a great administrative team to be able to make these things happen. These things don't happen without a lot of effort, a lot of attention to detail, and deep knowledge of the institution and our surrounding environment. So that being said, I am also in concurrence with the amounts that were proposed by you and moved by Mr. Wallace.
Thank you. Dr. Danielson. I said director. Dr. Daniels. I'll do whatever you like.
Thank you. I was listening very intently to the other board members, and I don't want to reiterate everything they said because I am in total agreement with them, but I would like to put my interpretation, my spin on it the way I see it. I've been working in healthcare for a great number of years, and it seemed like it was a nice, simple operation in the beginning. And it has grown in complexity in a way that I don't have words to describe. All of those represent changes. Changes are difficult to deal with. These are, in some cases, necessary changes. And in other cases, I begin to wonder, what is the government doing? Why are we having these changes? And we could debate that till forever, but it's not going to change anything. The changes are here. We have to deal with them. There's no other choice to it. I remember years ago, there was a major organization that came out and gave a dollar amount of what it would cost to implement ICD-10 throughout the United States. At that particular time, I said, I'll clean this up, it was baloney, because the cost was going to be far in excess of what they predicted. And when I see the amount of the money that we're going to have to spend tonight, over $7 million, just this hospital alone, and you multiply that out by the number of hospitals in the United States, again, that's a good example of the complexity and the amount of money that is being expended today that we have no control over to manage this particular operation. All of those represent tremendous, tremendous changes, and I see the way this hospital is progressing, and it is very, very impressive. It can't do that. The whole operation cannot happen without proper leadership. The leadership is what makes the wheels turn. They obviously turn very, very well. We had a magnificent presentation tonight. This hospital now has a pharmacy residency program, and that is a tremendous accomplishment for a district hospital, for a hospital that started out so that people in this district wouldn't have to figure out if they were going to meet their maker going either north to Oakland or south to San Jose on freeways that did not exist at that time. So we've accomplished a lot because we've had good leadership at this hospital, which inspires the remaining staff to also strive at that same level. We've received awards after awards, recognitions after recognitions, and it's amazing. It's amazing how this the whole operation actually comes together. And I would like to remind everyone too, this is not just a hospital. It's a district that is inclusive of, yes, the hospital, the outpatient services, not only in this area in Fremont, but also in Newark and in Union City. So sometimes I think that people think of what we do, it's just reflective of that one building. But it's not one building, it's many, many buildings, and it's many, many services spread throughout the whole district. And that's a big job. Director Wallace thinks in terms of the amount of money, and I think in the terms of the amount of services that are provided to the people who live here, and not only them, but other people who come here from outside of this district, outside of this state, to receive some of the services that we have here because of the quality. That doesn't happen overnight, and it doesn't happen just on a whim. It happens because we have good leadership. That leadership is coming from Nancy Farber. And I have to agree with all of the terms of the motion. And as Director Stewart said, we wish we could give more money, but we can't. She's a tremendous amount of experience, and I think with all of these changes, That is probably one of the key things that I see. So we need someone at the helm who has the experience in order to keep this operation moving forward with quality services for each and every person that enters our system. Thank you.
Thank you, Pat. Director Epen, do you have any comments for us?
Well, I think pretty much everything has been narrated, and the only thing that I would probably add on is that, I worked, practiced healthcare in about 3 different continents around the world, and I don't think at any point I have seen so much of changes happening at the same time in the healthcare industry, and it's like a storm. And to weather the storm and to go through this, you definitely need an experienced, pilot. And I think that's what our CEO brings to the table. And regarding the salary, I think we have always discussed that, the market value, and that's what it is. We have always tried to, keep up with the market rate. But after every year, even with this supplements or changes, I think we are still behind the market rate. So, I have no issues in seconding the motion.
Thank you. I'd finish this discussion by pleading with the community to recognize the jewel that this hospital is. The services this hospital offers are unprecedented for a district hospital. And we have had a history of tremendous service to this community. I'd plead with the community to recognize that and to try and understand the challenges that we face, the unprecedented challenges. It seems as though every turn we take as a hospital is met by someone finding some way to take money away from us. And it's extremely difficult to maintain a bottom line and maintain the hospital as it is today. We are under stress that is almost impossible to reach. And I'd plead for understanding. I'd plead for the idea that we're moving ahead in the best way we possibly can move, with leadership that is proven, with leadership that has shown tremendous ability to find answers in difficult situations. So with that, I'll call for a vote on that. I would like Catherine to call for a vote by individual, if you could.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
That motion passes. We could now move on to item F.
Mr. President, in accordance with District Law Policies and Procedures, I move for approval of the proposed amendments of the Washington Hospital Medical Staff Rules and Regulations Manual. This was reviewed in the Joint Conference Committee.
Second?
A motion and a second. Any discussion on that at all? We've seen those regulations and we want to keep our medical staff in good shape. All in favor?
Aye.
Aye. That motion passes. There being no further action items or on our agenda for this open session, I'd like now to adjourn to a closed session. We reconvene this meeting to open session and announce that no action was taken in the closed session. There being no further business tonight, this meeting is adjourned.